I've been asked to give a talk about stenting the venous system and the Fontan circuits, and we'll divide this into two sections, therefore. In terms of the venous side, the clinical scenarios that we come across are situations where there is an acute loss of lumen, such as after intervention. We can get dissection, which again can lead to occlusion or stenosis. We can get perforation of the vessels, and we can also have to deal with sometimes chronic occlusion. These are usually patients who've had long lines for a long time, patients waiting for small bowel transplant, patients with waiting for liver transplant. And sometimes these are iatrogenic, in other words, after surgery, say for a sinus venosus ASD or for a mustard sending procedure. So why do we do it? It's not just to open up the vessel, but by opening up a vein, you improve the circulation because you're improving the flow. It reduces the high proximal pressure, so if it's in the lower half, you avoid them having varicose veins and problems with that. If it's in the top, sometimes they have problems with headaches and cyanosis, as well as enlargement of the head. There is a risk of thrombosis when you have very dilated veins with stagnant flow, and if these veins can be connected to the systemic circulation, as they sometimes do, through collaterals, you can finish up with systemic embolization. Obviously to improve symptoms, and sometimes we need to establish an occluded path, either for pacing, for intervention, or to place long lines. Now, in terms of crossing the obstruction, there are various things depending on where the lesion is, how long is it, whether it's straight, curved, and so on. So if it's a straight course, such as an inferior vena cava, we can use a straightened transeptal needle, although we don't use that very much these days, partly because it's got to go over a sheet and therefore you can create quite a big hole. A straight Terumo 018 wire pretty much goes through anything, so it is a very, very good wire in terms of overcoming chronic total occlusion or even acute occlusion. But the CTO wires, which I mentioned yesterday, are an alternative. The advantage of the CTO wires is that they are 014 as opposed to 018, and therefore you can place a coronary balloon to open up the track so that you can put a bigger wire and then a bigger sheath. The Baylis radio frequency wire is also very useful in this situation. The only slight problem with the wire is that you have no control as to where it goes. So it can actually move, you just can't direct it in the position that you want it to. Laser is an option, but in practice it's not used. There's too many logistical problems with laser. But it certainly does work. In terms of stents, the usual, we can either use bare metal or covered. In the majority of instances, a bare metal stent is sufficient. But for larger vessels, we need to use graft stents. And some of these graft stents can be customized, and they should be customized as the vascular surgeons also have them customized. So you can do CT, MRI, make the measurements, and then you can ask the companies to actually give you a device appropriate to that particular patient. Now, sometimes it's very difficult to be 100% sure about the length, even on CT. So in that situation, what you could do, instead of using one stent, you can use two stents, which you telescope one into the other, and you can adjust the length accordingly. And the idea of that is to make sure that you do not jail any important veins. And I'll show you an example of that. There are obviously balloon expandables and self-expanding stents. Certainly if you're putting stents in vessels and veins where there is a lot of movement, such as in the neck or in the groin, you should use self-expanding, because the other stents tend to collapse if there's any pressure. So this is an example of a patient who had transposition of the great arteries. Oh yes, so it's working on there. So this is a patient who had transposition of great arteries, finished up with an arterial switch and bilateral pulmonary artery stenosis. He also had an occlusion of the iliac vein up to the proximal IVC, and for reasons of circulation in his legs, but also to get access to the pulmonary arteries for dilatation, we placed a series of telescopic stents successfully. Now, some of the problems that can arise are from intervention. And this is a patient who had a very simple condition known as a patent foramen ovale. And when the operator went in with the sheath and brought out the dilator and the wire, you could see that the wire was actually bent. And I was very concerned about that because it means that the wire went into the femoral vein. And therefore, when you pushed the dilator up against a curve, you can actually create a tear. So I asked the operator to do an angiogram, and you can see that there is extravasation of blood. You can see there that we then placed a self-expanding covered graft stent, and although it looked in a good position, we were still getting some flow here. And remember, venous flow doesn't stop on its own. The vessel doesn't go so much into spasm. So again, telescoped graft stent on that to stop the bleeding altogether. So I think it's very, very important that if you see the wire that you used to put the sheath in curved, that you may have caused damage to the femoral vessel. And again, in fact, it was the same operator, similar problem, caused that kind of on a different occasion. Now, it is important to have graft stents available, and we did have them. I said to the catheter lab sister, put them in a safe place. And when we actually needed it, she wasn't in her office. So the only thing that we had at the time was a covered CP stent, which we did use. I wouldn't necessarily recommend a balloon expandable stent when there is a tear. I would much prefer to have a self-expanding stent. After about 10 minutes, she appeared on the scene, and she told me, yes, they are in a safe place in my office, but she didn't tell anybody about it. So we all now know they are there in her office. So we placed a graft stent, which is self-expanding, and again, with a good result. This is a patient who had surgery for TAPVD, sinus venosus with partial anomalous venous drainage, finished up with occlusion of the SVC, also needed pacing because of episodes of asystole and intermittent heart block. You can see there's a gap at that point there. There's filling of the azygos vein here. We crossed this with a CTO wire, and the patient was actually following surgery with a big head and sour-nosed. We tried with a high-pressure balloon, and the waist wouldn't go, so we used a cutting balloon, which did the job very nicely. These venous stenosis can be very, very tough indeed. We placed the stent, but clearly the flow was not complete. In other words, that we had not covered the stenosis completely. So another stent is placed to cover the lower end, and by the end of it, we had a very good flow, and we dilated that about a year later to 12 millimeters without any problems whatsoever. This is another patient, again, a sinus venosus ASD, operated on. You can see the occlusion of the SVC there completely. Again, in this situation, instead of using a CTO wire, because we're not using them at the time, we used a transseptal needle. We had biplane, so that it could be coaxial and make sure that we're going in the right place. And you could see that we've got a stent at this point here. There are a lot of angiograms done at this point before the transseptal or during the transseptal needle use, and therefore you have a bit of extravasation here, but this is of no consequence. The important thing is you have good flow now, and we were able to actually place a couple of pacing wires at the same time. Patients with mustard or sending operations, these operations are more done now for corrected transposition rather than simple transposition, but there are some older patients that still have them. As you can see, it's very nice. There's a very nice rat tail here, which can be accessed from above. Initially, we used a radiofrequency wire, and we knew that we were in the heart because you can see the wire moving. But on echo, it looked like it went into this pulmonary venous atrium rather than the systemic venous atrium. So we pulled back and we used a transseptal needle, which I have to say I do prefer. It gives me the pressure, it gives me more control, and I can adjust the curvature as necessary. And we were able to establish circuit at that point from below. We could have deployed it from above, but I prefer to do it from below. Placed a stent there and then completed the procedure by putting a second stent there. I will, this is very similar, so I will go to the next lot. This is a patient who had stenosis of the innominate vein. This is after placing a defibrillator and multi-site pacing. He had quite a lot of problems with headaches, and we had to take the pacing system out. A vascular radiologist placed one of these self-expanding stents. Sometimes when they're very long and you've got this kind of anatomy, they can finish up like a toffee wrapper, and therefore you finish up with stenosis within the self-expanding stent. So what we did is we just placed a balloon expandable stent. Remember, these are not going to be compressed at this level of the innominate vein. They're within the chest. And once we've done this, we were able to repace him and defib him. As far as the Fontan circulation is concerned, IVC occlusion is certainly a possibility. A lot of these patients will have occlusion, usually from before, because they would have had stage 1, stage 2, and so on. So long lines on the intensive care unit with a lot of drugs and so on. And when they have occlusion, they can finish up with problems, primarily gastrointestinal, ascites, and lower limb venous congestion. Sometimes we have to use them as exclusion therapy, either to close a fenestration or to deal with a dehiscence, particularly with a lateral tunnel Fontan. It's very rare that you get SVC to PA junction obstruction, and in most of these instances, balloon dilatation is usually enough because it's scar tissue. Very rarely do you need to put stents. As far as the pulmonary arteries are concerned, I think we can put stents. It's very easy to put stents, but remember, stents are not without their own problems. So I think we have to be a little bit careful about that. So this is a patient. I'm grateful to Aygun Dündar from here, from Istanbul, for the slides. This is a patient who had a Fontan procedure, finished up with a lot of ascites. There was indeed a clot in the IVC. We had to be careful where we placed this because there was the renal vein here and the inferior mesenteric vein here as well. The end result was, and the iliac here. So we've got the iliacs patent, we've got the renal patent, and we had an improved flow in that situation. There are some units like Paris where they're using covered stents to close fenestrations. I personally don't think it's a good idea. I think you can close a fenestration with a device. But this is a patient who had a lateral tunnel Fontan, finished up with a lot of desaturation postoperatively, and the intensivists were pushing gynotropes like there was no tomorrow. And when I saw the patient, I said, well, the desaturation is not due to low cardiac output, but due to a dehiscence of the patch. So we placed an ASO device, an Amplatz ASO device there, improved the saturations from the 50s to the 70s, and some years later, we wanted to complete this, so we used a tag from Gore, a self-expanding graft stent, to close the dehiscence at that point. We then telescoped it right up to the pulmonary arteries and sculpted it with a soft balloon, and that is the end result. You can see hardly any flow there, and again, you can see the lateral tunnel. It's become a lateral tunnel now rather than a lateral. Sorry, it's become a TCPC rather than a lateral tunnel Fontan with hardly any flow whatsoever. This is a patient with an occluded IVC, hypoplastic left heart, and he had this occlusion after stage 1. He was on intensive care for a long time. We know that there are problems with Fontan patients with liver dysfunction as time goes by. This patient developed a very, very, very tortuous vessel, which eventually went up to the azygos vein, but it also linked up to the pulmonary veins on the right-hand side. So the concern here was, one, he had some renal dysfunction. He also had problems with his lower limbs. He had varicosities in his legs. And we were concerned that if he develops clot in here, even though he was anticoagulated, it potentially could go through the pulmonary veins into the cerebral circulation. So we got, after the CT angiogram from the leg, we got various angiograms from the top and from below. There was clearly a long segment which measured about 11 centimeters, but the radiologist couldn't be 100% correct about this. So we wanted to make sure that we were going to protect this vessel, this collateral vein that occurred here. The reason for that is we knew that the left renal vein was actually draining into it, so we needed to make sure that we protected that. So again, we used a CTO wire from above, created a circuit from the top to the bottom, and then we placed a tulip-type graft. In other words, this is flared at the top and it's not covered, and the rest is actually covered. We then use a second stent upside down in a tulip-type fashion, so the graft-covered stent would be there and the flare would be here, and the flares are actually not covered, and that's to protect the renal veins. And the final result was that we did have a good connection. The renal veins were protected. The advantage of these telescopic stents is that we had a range of between 9 and 14 millimeters that we could play with. The CT suggested 11 centimeters, but to adjust it appropriately, having these telescopic stents is very important. And you can send the data to the manufacturers and they will do it within about 3 weeks. And the CT, again, shows that the stent is behind the liver there. This is the track that we created. We didn't go through the old IVC, obviously, and that was it. We had no extravasation whatsoever. As far as the pulmonary arteries are concerned, in a Fontan, sometimes mild stenosis is relevant, and it is easy to do because it's a non-pulsatile circulation. However, stents do get into problems. There is in-stent stenosis, there can be compression of the aorta, and so on and so forth. So if there's an indication, I have no problem, but I think to actually do them routinely just because the angiogram looks a little bit unusual as a matter of routine, I personally do not agree with that. So, in situations like this where most of the flow is through the right and there was like a twisted left pulmonary artery, I think I have no concerns with that, but you can, especially if you use too long a stent, you can actually jail some of these vessels. And it may not be 100% important, but for a Fontan circulation, you need to protect all the vessels that you have. So stenting of the venous and the Fontan circuits has become a very common practice and is routine, and increasingly, because we have more patients with more difficult problems on ITU, long-standing lines, this is going to become an issue which we have to deal with. Most of the radiologists don't seem to want to deal with it, at least in our institution. There are a variety of tools, both to perforate, but also in terms of stents and wires and so on. I think it's important to familiarize yourself with that. And I think in the Fontan circulation, I do have concerns that some people are putting in stents with very, very little indication in a Fontan circulation. If they have a problem after surgery and they have persistent pleural effusions and so on, then I think it is important to consider it. But what often happens is people do more than one thing at a time, so they either enlarge a fenestration and put a stent. I would much prefer to do one thing at a time. I have seen stents into pulmonary arteries become either very narrow or completely occluded because of ingrowth stenosis. So I think we need to be judicious when we actually place stents, even in a Fontan circulation. Thank you very much.